Let's talk about nicardipine. Click on the link. Interesting information can be found. Indications, dosage, monitoring, instructions. Here's the structure of nicardipine as well as a label. Nicardipine functions as a calcium channel blocker, specifically slow calcium channel. Think of it as a calcium ion antagonist. It inhibits calcium influx into heart muscle without changing serum calcium concentrations. It does this more selectively to vascular smooth muscle when compared with cardiac muscle. In experimental animal models, this drug produces relaxation of coronary vascular smooth muscle. This drug causes little or no negative inotropic effects. Negative inotropic agents weaken the force of muscular contractions. Positive inotropic agents increase the strength of muscular contractions. The term inotropic state is commonly used in reference to various drugs that affect the strength of contraction of heart muscle, myocardial contractility. This drug is used for short-term treatment of hypertension, especially when oral therapy is not feasible or desirable. Because this drug is meant to be temporary, prolonged control of blood pressure, you need to transfer your patients to oral medication as soon as their clinical condition. The main contraindication for nicardipine is patients with advanced aortic stenosis. Adverse effects of this drug include headache, hypotension, tachycardia, nausea, vomiting. Because this drug can have excessive pharmacodynamic effects, in other words, it can produce symptomatic hypotension or tachycardia, you have to monitor your patient's blood pressure and heart rate. This is especially important in patients who've had an acute cerebral infarction. This drug increases the frequency, duration, and severity of patients with angina, though this is not very common and the mechanism of this effect has not been established. In patients with heart failure, in which nicardipine is being used in combination with a beta blocker, there's possible negative inotropic effects, so you need to be aware of that. Use in patients with impaired hepatic function, you need to consider lower dosages because this drug is metabolized by the liver, and if they have hepatic function, they're not going to metabolize it as well. Also, patients with reduced hepatic blood flow is of concern. Patients with renal impairment also present an interesting case. They have a lower systemic clearance and higher area under the curve, very similar with what is seen after oral administration of nicardipine. The same is true of IV administered nicardipine. The bottom line is you should titrate gradually in patients with renal impairment and liver problems. Geriatric patients also present a unique situation. Use low doses initially in elderly patients. That's because of the fact older folks have a greater frequency of liver, renal, or heart dysfunction and a greater frequency of concomitant disease and other co-administered drug therapies, so you have to be careful with geriatric patients. In general, though, nicardipine IV can be used safely concomitantly with other beta blockers. However, again, titrate slowly. Cimetidine, also known as Tagamet, an H2 receptor antagonist, has been shown to increase nicardipine plasma concentrations with the oral form. Data on other H2 antagonists are not available at this point, so for now, cimetidine is of concern. Administering together with cyclosporin can present a problem. Nicardipine-mediated inhibition of hepatic microsome enzymes, cytochrome P450-3A4 specifically, one of the more important drug metabolizing enzymes in your. So as a physician, you need to closely monitor plasma concentrations of cyclosporin when mixing it with nicardipine and reduce the dose of cyclosporin accordingly. Another immune suppressing drug called tacrolimus needs to be administered with care when combining with nicardipine. Again, nicardipine-mediated inhibition of hepatic microsomal enzymes like CYP3A4 can contribute to a rise in tacrolimus concentrations in your patient's serum. So you have to closely monitor concentrations of this drug. In pregnancy category C drug, no considerations for labor and delivery. In nursing mothers, it's minimally excreted into human milk, so you need to consider the possibility of infant exposure when using nicardipine in nursing mothers. And finally, with respect to nicardipine metabolism, it's a major substrate of CYP3A4, one of the more important drug metabolizing enzymes in your patient's liver and intestine. It's a relatively minor substrate of other CYPs, including CYP1A2, 2C9, 2D6, and 2E1. It's also a major substrate for P-glycoprotein, which is encoded for by the MDR1 gene. It's a drug efflux transport. So oral nicardipine goes through heavy first pass metabolism, whereas IV nicardipine does not. Okay, student doctors, that's all we have for drugs to treat aortic dissection. Thank you so much.